Welcome back, everyone, to our final session of the day. This conversation is going to be all about social determinants of health, and we could not have asked for a better lineup of panelists to discuss this topic. We've had some wonderful prep calls to prepare, and I really can't wait for all of our great panelists to share all of their knowledge with you. Want to give a big shout out to LexisNexis for supporting this session. Thank you, Jay. Without your support and your team support, this wouldn't have been possible, so we appreciate it. Check out information about LexisNexis on the website, along with all of our education partners as well. As you all know, you can ask questions two ways during this session. You can use the raise hand button at the bottom of the screen, and I'll be able to unmute you so you could ask your question live. Or you can open the chat box, which you all need to do anyway. So go ahead and get that chat box opened up. And if you want to ask your question in the chat box, you can put it in right there in the little chat section. One quick thing, if you do put a question in there, make sure you change the to line from all panelists and to all panelists and attendees. The reason you want to do that is there may be a fellow attendee that has an answer to your question. So again, change that to line to all panelists and attendees when you put your questions in the chat box, or you can ask your questions live by clicking on the raise hand button. And as I promised, we have a special announcement during this session, and we'll be making that at the very, very end. So thank you guys for joining us. I'm going to go ahead and get our panelists introduced, and then I'll turn it over to our fabulous moderator and and host, Mark Hagland, our editor-in-chief. But before I do that, I'd like to introduce Disha Dixon, who is the Associate Vice President of Community Wellness at Reading Hospital, which is part of Tower Health. Welcome, Disha. We have Dr. Brian Miller, who's the Chief Medical Information Officer at ProMedica. Welcome, Brian. Thank you. We have Dr. Jacob Ryder, who is the Chief Executive Officer of the Alliance for Better Healthcare. And of course, Jay Sultan, who's the Vice President of Healthcare Strategy at LexisNexis Risk Solutions. Welcome, everyone. And with that, I'm going to turn it over to Mark to have him introduce have you guys introduce yourselves a little bit more, and then we'll get started with the panel discussion. Take it away, Mark.
Thank you so much, Stephen, and thank you to you and our audience for being with us. We're so happy to have you, and thanks so much to our panel. I'm so excited. We've got wonderful experts here, and what I particularly love, which you'll hear about in 3 seconds here, is that they come from quite different backgrounds and different kinds of organizations. So before I do an introduction to our topic, let me just have each panelist take 1 minute and introduce themselves and their connection to the topic. Disha Dixon, would you like to go ahead, please?
Sure. Good afternoon. I'm so delighted to be here to talk about this topic. I'm Disha Dixon, the AVP for Community Wellness at Reading Hospital Tower Health. Reading Hospital is located in Berks County, which is the southeastern part of Pennsylvania. It's a suburb of suburban Philadelphia. We have a mixed population of very rural to very urban. At Reading Hospital, I handle all of the community benefit programming, a lot of the health equity, vulnerable population programs and initiatives, essentially to connect our most vulnerable patients to care.
Wonderful, thank you. Dr. Miller, why don't you tell us a little bit about your organization?
Yeah, so my organization is ProMedica. And we're sort of unique as a healthcare organization, historically, a growing provider footprint in the ambulatory world and in the acute care setting, kind of a traditional healthcare org, now up to about 1,200 providers in over a dozen hospitals. But we also have a payer arm that is broadly across the state and into some other states as well, with a big Medicaid component, which, as we know, has a big SDOH need there. We have about 600,000 lives covered in that payer plan. And then as of the last 2 years, with a big merger with HCR ManorCare, which at the time I think was this first or second largest for-profit senior care organization with several hundred skilled nursing facilities and home care and hospice and memory care. So we really live in the space of ambulatory and acute and payer and post-acute and senior world. And so we really kind of cover that spectrum. As the Chief Medical Information Officer for that system, I think the SDOH is really kind of the wheelhouse there, because if you're doing it right, it has to have a clinical connection. I come to that with years of experience as a family doc. And you can't do SDOH right if you're not doing it through really detailed, discrete informatics components and workflows. And so I think the informatics piece is how it all ties together and delivers the value of what SDOH interventions can bring.
Thank you so much. Dr. Ryder, many of us know who you are because of your work at ONC and in the past, but now you're working with a really fascinating organization. So tell us about that and your connection to it.
So yes, Mark, this is one of my first, aside from dropping out of college and working on a sailing ship, this is my first non-technical, non-IT job. So I'm CEO of this organization called Alliance for Better Health. Oddly, our original name was Alliance for Better Health Care. And when I joined, we changed the name because health is really what's important, right? And ideally, care isn't necessary. And that has been one of our guiding principles, is that health and care are very different things. We serve Medicaid members and the uninsured, and our goal is to improve the health of the people that we serve. And the byproduct of improved health, of course, is less care and therefore lower cost, right? But notice that lower cost is secondary to better health. And so we focus very much on better health. And of course, if we think about the three components of health care, social, behavioral, and medical, it took a family doctor like me to say this isn't about medical. This is about the social and behavioral health attributes. And if we can address issues in the social and behavioral health domains, then they won't cascade into medical problems. Yeah. And that's been our strategy for the past 4 years since I've been part of the company, and looking forward to sharing more about that later with the team.
Thank you. Terrific. Thank you so much, Dr. Ryder. And Jay, please share about yourself and your organization.
Well, thank you. So my name is Jay Sultan. Again, I lead strategy for the healthcare unit here at LexisNexis. I've been blessed to have a career that's always been focused on innovation in healthcare. First, payment bundles and other forms of value-based care. I've done a lot of work around the new interoperability rules coming out of the CMS ONC over the last 2 years. And I've been, ever since that landmark study that was done by the Institute of Medicine about the potential of SDOH, I've been fortunate to work with a number. I get to split my career roughly 50-50 between payers and providers, either working with products or doing management consulting. And so I've been able to work with a number of organizations, both on the payer and the delivery side, that have been trying to figure out how to leverage and use SDOH to change outcomes. And what are the barriers to doing so in the real world? So personally, I bring a lot of knowledge and experience from that realm. And in my role here at LexisNexis, we sit atop of a wonderful data set that we are able to leverage for a number of different use cases. The leadership here has a mantra around what we call data for good. We want to make sure that our data is being used in ways that actually promote better health, lower costs, better outcomes. And so among the assets we have here is a SDOH data set that we believe is distinctive in some ways. We might get to talk about that later during our session. And it's better than the alternatives for helping an organization do that initial stratification to figure out where to target and how to target resources and how to do so in ways that are aligned with the actual needs that any individual patient or member might have. So let me stop with that. And I'm just really excited to be here with such a distinguished panel today.
Thanks so much, Jay. Thank you all. Great introductions. So I'm just going to do literally about a 1 second or 1 minute level set. And then I'm going to have Dr. Ryder and Disha Dixon, Dr. Miller talk about their experiences in their organizations, and I'll have Jay add a kind of a nationwide gloss based on his perspective of what's going on. The thing that strikes me about this moment in healthcare with regard to social determinants of health, to me, this feels like a fulcrum point in some way, because we've learned a lot during the pandemic about a lot of the true gaps in health and in care in the United States. And at the same time, one of the things that has become painfully clear is that there has emerged no uniform approach to the social determinants of health. We have wonderful, wonderful organizations, including those represented here today, that are trying to find their way forward. But what is striking to me is that there still aren't really uniform definitions or vocabulary that we can rely on. Collecting data remains difficult, and we'll be spending a lot of time in a moment talking about that. And it's a little bit, it reminds me actually, I'm kind of fascinated by the early histories of the automobile and the telephone. And if you read about the early histories of those commonplace technologies in our lives, things were pretty confused for a long time. At the very beginning, most cars were custom, and literally people were putting core components in different places, right? Like in 2021 terms, you couldn't imagine getting into a new car and having the brake in a different place from where it is, right? Or the steering wheel in a different place. And yet that's how it was. So it feels a little bit like that around SDOH. And the same thing with the early telephone system, which are systems which are quite fascinating. You could only talk to the people who had subscribed to the same subscription service. And an early experience in Kansas City was helped lead to the Bell system, because people couldn't talk to their sisters-in-law because they were on the other subscription plan. So it feels a little bit like that. So Dr. Ryder, why don't you give us your overall gloss in terms of the landscape right now and what you see, and then follow that up, tell us a little bit about what your organization is doing, and then I'll move on to Disha Dixon for her sharing about her organization. But give us a little bit of your gloss of the current moment in this area, and then tell us a little bit about your alliance, which is so interesting.
Okay, thanks, Mark. I'm going to do something I've never done, and I am going to paste my notes into the chat. There we go. So everybody can see what I'm going to talk about, and we all get to cheat a little bit. You know, when I was in DC at ONC, we went to media training so we could handle people like Mark, and I learned about the 3 islands. And 3 islands are when you speak publicly and/or are being interviewed by a reporter, you always stick to your 3 points that you want to make, and no matter what question they ask, you just stick to your 3 points.
I've seen politicians do that very skillfully.
Absolutely. I think it was one of those training programs. So without belaboring that point, these are my 3 or 4 points, and I think I'll address some of what you were just talking about, Mark. So number 1, health and care are different, right? And let's make sure we don't conflate the two. And I think the way that many of us were trained, indoctrinated, brainwashed, et cetera, we were taught that these are the same. I was certainly taught that, you know, my role as a family doctor is to care for my patients. And, you know, without me, gosh, they would be up the creek, right?
Yeah.
And so that is a very egocentric way of looking at the universe, right? And so when we say things like providers, I've now learned to think way beyond medical providers, right?
Yeah.
Because if we are providing services, a homeless shelter is perhaps a much more valuable service provider than I am. So health and care are very distinct. Point number 2, horizontal work is imperative. What on earth do I mean about that? So what we have seen in our community, and you know, I'll talk a little bit if we get to it about what our organization has done. I would say that we are likely one of the most successful organizations in the country in terms of making sure that we are making the right investments in social determinants of health, measuring outcomes that document our health improvements and therefore reductions in cost, and then selling those activities to health plans, who are of course the ones who financially benefit from these activities. So we've done a great job, and not patting myself on the head too much. Part of that is because the work that we've done has been horizontal. And what I mean by that is that it's not siloed into one organization. It's not done with one health plan or one health system or one medical group. It's done region-wide. And this has been an imperative part of our success, is that we saw endeavors where, say, a given health plan or a given health system said, hey, this SDOH thing is really interesting. We're gonna whatever, support, we're going to provide housing assistance to people that are discharged from our health system, or people who see our primary care providers. Or a health plan might say, well, we're really, we're motivated to do food assistance, and we're going to, provide food assistance for everybody who's one of our members. And as soon as that second half of the sentence starts to get interjected, you start to create the siloization of social care services in a community. And although these things sort of make sense, that the whole concept of a narrow network and protecting against leakage makes sense when you're talking about knee replacement or cardiac surgery or things like that. It makes no sense in the social care domain, because we don't have the bandwidth. We don't have 14 homeless shelters to choose from in a community, right? We may have 2 or 3, and they are probably at capacity. And making them deal with different health plans or different health systems, their heads will spin off. And so what we've been able to do is create an infrastructure that enables us to work with the community-based organizations, and then we represent the needs of the community-based organizations as we engage with both the health systems, who definitely see return on investment. For example, we have reduced readmissions significantly, especially in the homeless members of our communities, right? Because we are making sure that they get respite housing or are placed in housing rather than discharged to the street. And so the hospitals aren't getting dinged for readmissions that are really readmissions for, folks who shouldn't have been discharged to the street. And if we can get them into housing, all for the better. So there's ROI in this for the health systems and for the health plans, but by horizontalizing it, we found that that's been an essential part of what happens. And this is against the DNA of many of these organizations, right? Many are very competitive and don't want to collaborate. There's a health economist named Len Nichols, and I encourage folks to read his papers on this, because he's very prescient and predicted that there would be resistance from especially the payer community in this domain. And using his models, we've been able to solve what he calls the free rider problem, wherein one health plan doesn't want to support an initiative that might actually benefit the member of another health plan. But if we look at this region-wide, the free rider problem is solved. And then last, closed loops are imperative. And this is where information technology becomes really important. And so when an individual has a need, it's not just the silos of activity that have existed in the sort of payment of and procurement of these services, it's also in the provision of these services. So one of the things we've done is to make sure that every organization that provides social services is also screening for other social problems. And so if you're at a homeless shelter, and now because of your involvement in our community, you're also screening for other problems. You're screening for behavioral health problems, you're screening for substance abuse, you're screening for medical problems. And then we've implemented a closed loop referral network. And so that part of the deal is that every organization both provides the services that they provide, but they also screen for and then make referrals to other organizations to meet those other needs. And in that way, close the loop and or if the loop isn't closed, and on my team, we have a staff of people who are sort of air traffic control, and we watch the referrals. And if a referral is never received, then we will do follow-up. We'll find the individual, we'll make sure that the recipient organization did receive the referral, that they act on it within a given time frame. And if that wasn't a good referral, and this was one of our learnings early on, was that organizations didn't want to say no, because these are benevolent organizations, right? And they want to say yes. But if somebody makes a referral to an organization and they don't provide services, what they would do is just sort of let that referral fall to the floor. Yeah. And we had to teach them that actually saying no rapidly is much better than just being quiet. And so a lot of this was education and learning together, because when they say no, then we can catch that ball, make the appropriate referral, and then make sure that that individual gets the services that they need. And so closing the loops, finding ways to interoperate with both across systems and across systems. By that I mean organizations, and across information technology systems has been really important. We have access to the health information exchange in our region, so we can see the clinical data, which ultimately is the dependent variable of our work, right? So if we see that acute care visits are down in people who have received services from social care providers, that becomes part of our return on investment, business case for the organizations that we interact with. Finally, I will offer just little notes in response to one of the things that Mark was asking. We are starting to see and therefore adopt standards. And as many know, ONC has engaged EMI advisors and the folks who are working on the Gravity project. So there's work in the vocabulary domain with Gravity. There's also work that the Administration for Community Living, ACL, has sponsored to work on closed loop referrals and how we can standardize referrals in communities. So we see HHS agencies really stepping up in this domain, and of course their ICD-10 Z codes to capture SDOH needs, and ideally then use those codes to transmit the needs of individuals. So I think that's over time, and I will hand the baton back to you, Mark.
Yeah, thank you. No, great insights. Thank you so much, Dr. Ryder. Disha, we would love to hear about some of the how you see the landscape and some of the advances that you and your colleagues have made. I think some of them will relate to some of the things that Dr. Ryder just referenced also.
Absolutely. Dr. Ryder gave some really key insights, and we share those insights, particularly the closed loop system. I think when we started out doing this, we first started out with a street medicine program, identifying our homeless population and providing them preventative primary care in the homeless shelter or wherever they were, so that we could keep them from coming into the hospital. And as we wanted to better identify them once they got into the hospital, what we found was that we could ask them the question, are you housing insecure? Are you homeless? We didn't have a mechanism to address that need, nor understand if they got the need met once we gave them a referral. So early on in our SDOH journey, that's what stopped us, because what was important to us was that entire closed loop. We didn't want to check the box, and asking SDOH questions really can't be for you. It has to be for your patient. And so once we were awarded funding through CMS, through the Accountable Health Communities model, we then implemented the full-scale SDOH model. And since 2018, we've completed about 110,000 screens. Mm-hmm. And some of the things that we've learned, again, very closely to what Dr. Ryder said, probably one of the biggest lessons is it's not about us as a hospital. Mm-hmm. We do about this much, okay? It's really not about us. So kind of breaking all that down and bringing people to the table and saying to our community-based organizations, like, you're really the stars of the show, okay? We need your expertise and level setting and creating that community collaborative where they feel valued. They feel like they're part of the equation. They're not just tapped into when we need them. So we started that process very early on. And then secondly, we really looked at who was going to be screening patients. I personally feel the person asking the patient the question is imperative. You have to really understand your patient population, mm-hmm. understand what barriers they may have to answering these super sensitive questions. I mean, if you think about asking a mom in a clinician's office, a pediatrician's office, if she has access to food, you want her to answer honestly because you want to be able to address that, but you also have to understand what that, yes, I need help with food answer may mean to her, or what she may think it may mean to her. And so we took a lot of time matching up our screeners to our patient population. Another lesson learned was we had to articulate the ROI of SDOH initiatives differently to different populations. So how I talk about SDOH ROI to my clinician friends is different than how I talk about it to my C-suite. It's different than how I talk about it to my CBOs, different than how I talk about it to my payer friends. It's the same message, it's just delivered differently because they all have different skin in the game. We use our SDOH data to highlight when we're able to lower readmission, avoid ED utilization, it's done through non-medical interventions. And that's when people say, oh, I can't believe. Yes, all these things are done through non-medical interventions. And it was something as little as using motivational interviewing techniques and understanding how this patient is prioritizing their health, right? So because we want them to get to their doctor, that may not be a priority for them because they're trying to figure out how they're going to house themselves, feed themselves, care for their children. So again, walking into these situations with, it's not about you. It's not about us. It's really about them. And how can we provide for complete total care for the patient? And like Dr. Ryder talked about changing the name of his organization, when I first stepped into this role, it was community health. And I asked for the name to be changed to wellness, because to me, really the work was about total wellness. And wellness was not just, did you get to the doctor? Have you seen your physician? Wellness was, do I feel 100% safe, comfortable, fulfilled? Can I lead a quality life? And that is, can I feed my family? Do I feel safe in my neighborhood? Do I have social connections? Do I have access to healthy food? So it was much, much more than access to care. And the last thing I'll say is, I think one of the lessons we can learn from Obamacare and the ACA is that simply having access or insurance does not mean you now have access, right? So simply saying now you have patients who have insurance does not mean that their health, their status of their health is better. And I think that to me was a big flaw. We see that with our homeless population. 85% of our street medicine patients have insurance, yet they haven't seen a doctor in years. So we know the two things don't correlate. And we know that the reasons why they're not seeing a physician have nothing to do with whether or not they have insurance, but more to do with how we as healthcare providers have set up institutional barriers. Yeah. And if you can't see us when we want to see you, then you're pretty much out of luck. And so a lot of the work we've been doing is identifying those institutional barriers, communicating to our internal and external partners about where they fit in changing this system, but then also empowering our patients to speak about what they feel is a priority and how they're defining total wellness.
Thank you so much. That was terrific, Disha. Really appreciate it. Dr. Miller, I saw you nodding your head a lot just now.
Yes, yeah. Some amazing work happening there, and a lot of stuff that that really resonates with our experience at ProMedica. I would probably start the story here in our traditional footprint, our ambulatory in our acute care space. 7-8 years ago, jumped into SDOH, really focusing on food and the food insecurity questions, the 2 questions, and doing some amazing things there that help prove that food truly is medicine. And that's a story for another time, because we want to stay data focused here as the central piece to this. And I'm probably going to hit my 3 islands and a couple sets of 3 islands, but I'm going to be as short as possible. In that space, we moved very quickly about 4 years ago from the singular domain of food. We said, this is making a difference, let's go whole hog. And we went to 10 domains, and now we're at 14 domains, and we're looking at a 15th and a 16th domain to screen for, especially our most recent one around. And what I was really nodding, I think Disha was connecting to a piece that we would call purpose, and we're screening for purpose. And screening for purpose and connecting people to life purpose can make an enormous difference in their life and in their health. But again, that's another story I'd love to tell in another one of these. But to the data piece, when we get to 14 domains, it was really important. The concept I think that I would hit over and over again for the audience here is that the data has to be discrete. So we embedded that piece into our EMR on our ambulatory side. Most of the time, those questions are answered in a patient portal. That's actually really important to our providers, because when you're at 14 domains, you cannot do that in a room anymore. That's going to take up 45 minutes of time, and you can't mess up my clinical flow. So we need that to be offline and be pre-visit, so they show up with those screening questions answered. And we get about 80-90% of our screens done that way. On the inpatient side, it's usually those people are sick. And so it's usually a nursing intake piece, but it's still a discrete format. And that just starts with data. So my positive domains are now discrete, and that makes them analyzable, that makes them reportable, and that makes them, in our life, longitudinal as well. And those three components start there with a discrete piece of data: analyzable, reportable, and longitudinal. Maybe that's my first three islands. That data then flows to a piece of software that's essentially an SDOH care nav module. And there's a team that monitors that piece, and they work that data. They make the connections, they make referrals, they service those things. And what they do in that module to start to connect people to care, sometimes it's our service, sometimes it's a CBO that we connect them to. That still means that all those first touches are now continuing to be discrete. And now I start to get more of that longitudinal component, which is important, because once you get downstream, you want to actually know that that outcome delivers to the need, or else you need to optimize your workflow in another way. So that's the kind of our traditional footprint. Like I said, we have a payer piece. We have 10 domains that we screen those clients for. Again, that is discrete. It's a little bit more of a struggle to get responses there, because people are more likely to connect with their doc than they are with their payer. But we push really our hardest pieces into our Medicaid population, because we know there's a lot of need there. And truthfully, from the payer side, they do that. Yes, they want to make a difference in a life, but they really like to reduce cost. And more the payers are starting to embrace the fact that SDOH interventions, when they matter, can clearly reduce the payer cost, and that's important. But we do those in a discrete way, and again, that's analyzable, reportable, longitudinal, and we connect them to downstream interventions. Generally, our payer uses one of the CRRP platforms that we'll maybe talk about if we have a little extra time, and they're about cost reduction. In our senior care space, because we're 2 years in, our journey in SDOH was kind of new to them, but it turned out they were actually doing a lot of screening. Some of it's regulatory in those spaces, but they still need to ask questions about, when you're discharged from a SNF, do you have food? Do you have a stable home? And so we worked in the past year to get their documents in a discrete format. And so right now that's added to our numbers, and we have it analyzable, reportable. We don't have a longitudinal component there yet. We're working on that, but we do actually help people connect downstream again through a CRRP platform. We are now averaging about 125,000 screens across those three big footprints on an annual basis. So that is a lot of data to parse. Yeah. That's one big island for me. The second big island is the more sophisticated stuff, what you do with that data. So again, mostly in our traditional footprint, because we have a more longitudinal connection there, we actually do a lot of patient matching in the background to claims data on those patients. And obviously that makes it, because we have a payer, we can do that. We have to be very careful about how we share that data, and it has to be in a clean room, because obviously our healthcare org side can't see costs, but we get aggregate data out of there. And so what that helps us do then is determine, once we make a connection downstream, what is our outcome, zeroing very hard in on, did the payer see a reduction in costs? And I really was nodding when Dr. Ryder was talking, because yeah, I'm a family doc. So the ego piece of that is I want to make a difference in a life. So, I don't know that I care about cost reduction, but for me, it's all about that triple aim. If you reduce that arm of cost, that means I've probably provided better health, and I feel good about that. My payer's, of course, going to feel good about cost reduction. My patient's going to feel good. I just got a better experience in life now because I'm healthier. And so turning that three-sided wheel is a really important piece of SDOH. And that really is, to me, delivers to the ROI value. And that's the outcome, that the cost reduction outcome is what gets everybody to the table. Healthcare orgs are there, payers are there, the government's there, the employers are there. You need to be very, very focused on cost reduction as an ROI for SDOH intervention, which is my third island. I promise it's my last one. But I think this is the coolest thing we're probably doing, and we're just kicking it off in the last several months, is to really essentially take the incubator around cost reduction and look at probably the islands, the three ways we do that. When you make a difference in a SDOH intervention, you've reduced admissions, you reduced readmissions, and you reduced ER utilization. That's how you drive the cost down. It's pretty clear. And so the interventions that you can take and then scale forward, we're now tying back to high medical disease burden. And we're taking patients that, lung cancer patients, bad COPD, heart failure patients, we know they already have an enormous amount of cost. And then we also know from our analytics that when you put an SDOH burden or two or three on top of the patients, you actually have multiples of that cost. And so we're using retroactive analysis. We take a demographic, we take some data around that patient that's publicly available. We take some proprietary data, some of which that we get from Jay's company, and we do a very specific lens around high medical disease burden and SDOH. And we know our docs are taking good care of this medical stuff, and we're going to make a difference on the SDOH piece for a small subset, kind of a precision pop health piece, and see if we can't actually make a really significant magnified reduction in that cost around the SDOH, so we can do very focal interventions. We think there's a lot of money to be had there. It's essentially kind of SDOH triage, if you will. And I think that's a really sophisticated way to use data to be very precise on where you can make the biggest difference the fastest. And I hope to be publishing that within the year.
Great. Thank you so much, Dr. Miller. So all three of you have presented just amazing insights already. Jay, now we come to you. I'd like to use you as a hinge panelist. And what I mean is I'd love to have you respond to anything that the three other panelists have shared overall, what we're seeing in the landscape of working with SDOH right now. And then you can pivot to, let's talk about the data, because all three have already tipped their hats, or even more than their hats, to this is going to have to be data driven. So again, start out looking at this nationwide landscape, what you see in relation to what the other panels have shared, and then we can tip into the data discussion.
Of course, and thank you for the opportunity. So nationwide, I would say SDOH today is a mission-oriented activity. And what I mean by that is people who care about outcomes, people who want to be driven by things other than bottom lines, are the ones who have led a lot of the initial work. And a lot of the initial work either had no ability to measure outcomes in return, or they weren't able to demonstrate scale enough to really get to the outcomes that they want. That's kind of the backdrop of a lot of nationwide, not thinking about the individual examples that were discussed here. And another way I characterize it is to say that today, SDOH is the work of heroes. What I mean by that is there are people who are willing to go, and organizations that are willing to go above and beyond without a clear understanding of what the return to the organization is going to be in order to do these things because they're the right thing. And that is heartening to me as somebody who works in healthcare and sees all the ones and zeros and the perverse financial incentives and everything that exists in healthcare. The problem is it's not sustainable. So, healthcare is a very cyclical industry, right? I mean, we were all talking about how big data was going to revolutionize healthcare. How many times do we use big data in a sentence these days? And then it was blockchain, right? So healthcare we love these great big cyclical things. And right now, we're still on the ascendancy for SDOH. But we have fundamental challenges we as a country have to address if we're going to keep SDOH from being one of those cyclical things. One of them is, and I'm just going to call out two islands here. One is to say we have to make it so that it's no longer work of heroes and it becomes part of our business as usual workflows. We have to take it from the exceptional to the ordinary, from the a side project that nothing's connected to and we put a lot of focus in to make sure it happens, to something that's integrated into the everyday. And that requires the integration into our existing workflow systems, not separate SDOH workflow systems that we expect clinicians, we accept case managers, we accept payer staff and stuff to be trying to log into. That means coming to national standards around how we talk about these things. I think the work that the Gravity Project is doing is fantastic, and we're looking as a company to figure out how we can better support Gravity going forward. But even Gravity is only really focusing on kind of a taxonomy around the actual delivery of community-based resources, where there's a much broader need for a common language set that addresses more of the kind of end-to-end workflows that have to happen in SDOH. And we as a country are going to have to get to those common languages very, very quickly, especially as we start thinking about some of the great resources like Aunt Bertha and others who really are more national in scale and need to think about this beyond just kind of one community's closed loop system. And I think the other area that we have to do better on, that as I look across the country, and you've heard in the examples that all three of the panelists have spoken about, is the need to understand and get to ROI. Well, ROI has to start with a way of understanding and measuring outcomes. And our ability in SDOH to, in even an anecdotal way, nevertheless in a systematic way, to really understand and measure outcomes. And as I think it was Disha said, outcomes in the context of the different stakeholders who are involved, that's something where as a nation, we're nascent. And simply put, there's going to come a time where we're not able to fund mission-oriented activity without the evidence that it is creating a return that we understand. And when payers are in the room, we have to be thinking about that in the context of the roughly 18 months that any payer might have a member. So, it does no good for most payers to solve problems 20 years from now. They're needing to solve problems before the member churns. For a lot of delivery systems, it's about not so much, what I loved about what I think two of the panelists said is you got to make it about what the patient, what the member, the patient needs, as opposed to what it is I happen to deliver, right? If I've got a bag full of community-based resources and they become my hammer and I'm going hunting for a nail. So I'm mindful of, early work that an organization like Carebore did. They're now acquired by Anthem and they operate as a delivery system. There was a time they were a standalone integrated payer provider organization. And long before Uber or anything else, they recognized the need for transportation. They couldn't get reimbursed for it. So they just went ahead and bought the company and started providing transportation free to their members. And they did it because they achieved an ROI that made sense within their existing financial model. The model they're working on now is, or more recently, it's been around concepts like companionship and stuff. And again, this is a payer saying, how can I meaningfully bend the needle on companionship? And what I love about what they're doing is they had a way to say, by doing these things, we have the following return we can measure. Those kind of things we have to scale to. So that's my reaction to what's been said. And with your permission, I will now hinge and go to the topic of data. Because what you heard me describe is we need data on outcomes that we can use to understand, are we actually doing any good or are we just making ourselves feel better? And we need data that works within our workflow systems. So our workflow systems are data and process centric. And there's lots of elements of data in SDOH. The area that I focus on, I heard Dr. Miller speaking about it a lot, is really around the stratification. There's limited resources, limited time, and it does no good just to say, who are my homeless people? It does better to say, who are my homeless people with whom I can create an impact? There's three basic ways organizations get data for stratification. The first is you can ask the patient, the member themselves. You can do surveys in an ED, you can do health risk assessments, et cetera. And I think that's always going to be an essential critical part. That's how you find out what the patient needs. You don't ever get away from that. But if all you have is that, you have at least two problems. One, you only have data for the people you could interview. And a lot of times, some of the most impactful audience are the people you can't interview, that you're not in touch with and contact with yet. So you do need more comprehensive views of the data of the population you wish to address. The other problem is, intentionally or unintentionally, we can't always trust the data that we get when we interview the patient, the member. Sometimes they're ashamed, sometimes they don't know, sometimes they have other motives, whatever it is. There has to be other data sources. So an external data source that a lot of people have started trying to work with in the last couple of years is to use census data. If I live in a census block, I know most of the people in that census block are housing insecure. I know most of the people in census block have income issues. And I'm going to treat everybody in that census block that way. Or maybe I'll get a data set that starts with that and says, but this person has a subscription to a men's magazine. So now I can infer that this is somebody who really thinks about their health. I think all of that is a little specious. I think the real opportunity is to work with a data set that really it uses as its source, not free census data, but uses as its source a very robust network of inputs that come from governments and all kinds of other institutions. LexisNexis, for example, we have a data set that's got 442 attributes, none of which are clinical. And they're all things like, does anybody in your home have a driver's license? Or have you lived at a bunch of addresses that we know, within a space of 2 years, or that we might know to be a homeless shelter? And all of these attributes we have established to be independently clinically significant to the clinical outcomes that we're all trying to chase. By using data sets like that at the beginning of the process, we can do a better job of stratifying and targeting our resources, and then being able to get into the workflow. And again, that workflow is, I've identified the patients, I've spoken to them, I've learned about them, I know more about them. Now that I've done that, I'm able to identify what community-based resources are available or what's needed. I can prescribe those resources. I can ensure they actually get the resources, and then I can go back and measure the outcomes. That's the workflow that we need to get to. And as we think about the data, I think it's healthy to think about the data as it walks us through that workflow.
Thank you so much. Great insights. I'm going to add one tiny little dot of information based on a presentation that we had in one of our in-person sessions about 1.5 years ago. And it was the University of Michigan, now known as Michigan Health. And they're based in Ann Arbor, where the University of Michigan is. And they did, I forget the correct term, it was something like hot spotting or something like that, but they started doing zip code and sub-zip code neighborhood data canvassing, I guess you'd call it. And they realized, and there's a piece that's obvious and there's a piece that's non-obvious. They were looking at the insides of zip codes and looking at where it appeared that that individuals were having very poor quality of life for a number of reasons related to SDOH. And they actually highlighted upon a zip code in Ann Arbor where there was a trailer park where people were at very low levels of socioeconomic well-being, but it was inside a zip code that was otherwise relatively affluent.
Exactly.
And what they discovered was, wow, we can't just even look at the zip code level, we have to look at the sub-zip code level, because most of the people in that one zip code, and I don't remember which zip code, and it wouldn't really matter anyway, were doing pretty well, had pretty good quality of life. But the people who lived in that trailer park, not too surprisingly, were at a lower socioeconomic level, and also were experiencing far higher levels of ED visits. Some were uninsured, all the things that you would imagine. So I just thought I would mention that because there are many ways to get to slice that lemon. But my one question, and I see we should have made this a 3-hour panel because we're never going to get to all this. I know, right? But my one quick question, and I don't know whether we can answer it rapid fire because we now have 5 questions from the audience, but super quick, what do my panelists think? Is there some magic key in terms of so where we can create some more standardized process among all the organizations doing this? Because it just feels as though, what I said about the early cars, like the brake is in a different place and the gas is in a different place, and all of that. Are there 1, 2, 3 things that we as an overall system can do nationwide to make this not so difficult, where everyone's reinventing the wheel every minute? Does anyone have any thoughts?
Maybe we all give one version. There's probably 10 answers to that. We all just maybe throw one in. Would that work for you? So I'm going to start because it's something I'm living with right now. The cool, sophisticated stuff that I talked about, the cohort analysis, and Jay's got some tremendous things that his company's doing there. And there's a great synergy there. But the regs are actually behind us. And when I talk to my compliance officers, I sometimes get held back and handcuffed on how deeply I can analyze patients' data, because SDOH is still considered separate. It's not within the scope of care. It's not a medical service. I think everybody in this panel will go, yes, it is, because these interventions, Jake started with it. He said an intervention with food is way more important than the pill I'm going to give you for blood pressure. But the regs aren't up to date. And I would just, for the audience, I would say there's a proposal right now, and it's in comment period. So steer it to you. The Office of Civil Rights out of the HHS is looking at updating the HIPAA privacy rights in a way that would, I think, strengthen them for the patient and allow us in healthcare more liberal access to utilize that data in a meaningful way to do sophisticated analytics to drive to this. So, so we need the regs to catch up, and that would be my one.
Disha, I bet you have a thought.
I do have a thought because I'm in a state where we have many hospitals, community organizations who have, I think it was Jay who said SDOH heroes, who have noticed that SDOH was an issue in their population and taken it upon themselves either through self-funding or through grants like Reading, and started to do this work. And so you have all of us moving at different paces, achieving success. To me, I think our state and federal leaders need to come in and really set the standard. I think they need to help, because the way it is now, it is completely unsustainable. This type of work is huge. I mean, Dr. Ryder talked a lot about coordination across every level. This can't be a corner of your desk job. The staff that I have, this is their job. This is what they do every day. I think Dr. Miller talked about looking at workflows and figuring out downstream if your workflow needs to be changed. You can't have someone do this work occasionally and change the workflow. They have to be studying that data and understanding where the kinks are, where the flaws are. And so to provide funding for that staff and that level of staff that are trained, that can do this work every day, that can analyze that data, but also staff that can go out and work one-to-one with patients, like a community health worker. You need varying skill sets, various people across the table. And so to me, it's very surprising to me that our state and federal leaders haven't really stepped in to say, we know that this works. We know that there's costs to be saved here, and then direct our payers. I don't know, I think it was Dr. Ryder who talked about individual payers saying, you can do this, but you can only work with my members. And we've tried to stay away from that, because that's a burden on our staff. You know, to have patients come into an office and say, I can talk to you about your food insecurity, but not you, because they're not paying us to do that. And so who wants to do that, right? So we'll spin on our another health equity wheel, and that's another webinar we could have. But to me, I really would like to look to our state leaders and our federal leaders to say, catch up. We're doing this work. We really need you to come in and help us fund it so we can keep helping our patients live their best life.
And oh yeah, thank you. Let's raise our glass of water. I'll raise my Mozart cup here, which my cup with Mozart on it. Anyway, I was just going to say, I totally support what you just said, Disha, because listening to this discussion, and all of you are providing just brilliant insights. I'm loving every insight. At some point, this has to become a federal and state priority, an agenda item, and something where, you know, state Medicaid departments, for example, get involved, because I think you said it, Dr. Ryder, first, but then everyone else basically said the same thing. We can't do this one hospital or health system at a time. As heroic, like your organization, Disha, and yours, Dr. Miller, heroic work. But at a certain point, it becomes a policy issue, because as Jay noted, I mean, otherwise we're going to be doing the early version of automobiles and telephones for the next 50 years, right? Like, one of the things that happened with automobiles and telephones is people realized, wow, this isn't working, right? Like the Bell telephone system came about because it was a chaos. And in Kansas City, there were 4 systems, and you could only talk to people who were subscribing to the same system. And people found out their mother-in-law was on one system, their cousin was on another, their neighbor was on another, and the grocery store was on another. And eventually they realized that that just did not work. Like, you could never have a nationwide phone system like that. So they created one. So I think there's a policy discussion to be had. But let me just ask briefly, we are almost running out of time here, and we haven't even gotten to we really haven't gotten to the questions, and I apologize for that. What I would like to do, since we have 5 minutes, is have each panelist take about 1 minute, maybe 1 minute and 10 seconds, give us a piece of advice or a prediction for the next couple of years, a final word that you'd like to leave, final insight for our audience. Dr. Ryder, you get 1 minute and 10 seconds. Sorry.
Maybe I'll take less. My advice is going to be redundant of my previous expressions. Work together. And I think, what Mark was talking about, so my prediction, state and federal government leaders will continue to collaborate toward shared investments in this domain. I'll offer in New York, because it's budget season and our state budget is 2 weeks away, I've been lobbying for the state government and the Medicaid program to fund a per member per month flat fee to organizations like mine to horizontalize these investments, right? So instead of each managed Medicaid plan choosing how much or how little to invest, there would be $4 per member per month that just flows to an organization like ours. We would then support the CBOs and we would provide infrastructure along those lines. I think it's imperative to have community-wide activity. And so my advice is, if people work in organizations, find your counterparts in your competitors, work together with them, and then find community sponsors to glue it all together.
Wonderful. Disha?
Yeah, well said. My prediction is the same. I think we will see some more collaboration with our state and federal funders. But my comments are to organizations that are thinking about doing this work and thinking about stepping into this space. My advice is do it. Don't be afraid. This is a paradigm shift. It's a huge step away from what you're currently doing, but you can do it. And I would say first steps, get to know your community. We use that zip code level data. I do the community health needs assessment for Reading Hospital and Tower Health. And one of the things that we've identified is we have 3 hotspots. We have 3 zip codes where we have high poverty, high crime, high unemployment. We have high ED utilization, high readmission. When we start to layer our SDOH screens on top of that, guess what? It's the same. The zip codes are the same. So these issues don't become huge. You can wrap your arms around a zip code. You can, instead of the whole county. So if you're saying hunger is an issue in Berks County, actually hunger is an issue in this zip code. And then you can do targeted outreach to that zip code. And you can start to think about, how do we communicate and market to people who are in that zip code? So if you're thinking like, there's no way I can screen every single person that comes into my ambulatory practice, screen everyone who comes in from that zip code. Start there. Start there to prove your case. So that's my advice. You can do it. If you take chunks out of it, it's not as scary as you may think.
Right. Don't boil the ocean. Right.
Right.
Thank you.
Good point.
Dr. Miller, you have about a minute.
Yeah. So while I think we're all doing really cool work that we're trying to figure out ways to make more sustainable and scalable, I worry the most about the things that are rapidly trending in the wrong direction. And for me, that's the health equity disparity between the top and the bottom of society. That is moving real hard. And maybe it's because of my other title that I didn't throw in there is I'm now Vice President of Telehealth, because we're doing a lot of that in COVID. And I feel like very specifically the trend from the top and the bottom, and it's getting wider, is the digital divide. And our studies have indicated that digital divide correlates to health literacy issues, and health literacy issues correlate with really poor outcomes. And until we step up and figure out a way to close that digital divide, and I think probably publicly just realize that it's a public utility like roads and water and electricity, because it's an important way going forward for people to connect to healthcare from just knowledge to actual care, then we're going to have issues, and digital divide's got to be answered and fixed.
That's right. Thank you. And Jay, you have 1 minute, and I apologize for that.
Okay. I want to, every single thing the panelists have said, as I was formulating my answers, they've all gotten said by the panelists. So I'll just make it really tactical. As you're building programs, build the measurement of outcomes into your programs. Work backwards from, why will we do this forever? How do I justify it? And I'm not saying you have to be completely coin operated. I'm saying think it through from a coin operated perspective, because that's a key part of sustainability and also getting scalability. And my prediction is that I think we will find the federal government, based on comments we got from the new secretary of HHS, interested in figuring out how to lead. We need to start compensating for the Z codes. We need to start mandating their coding, and we need to create more standardization across the breadth of the process so we can have a common lingua franca.
Yeah, absolutely. So first of all, I say hallelujah to every single thing all four of you have said just now. I agree absolutely, and I agree we need to create some kind of set of formulas or pathways that will move us forward, so we're not recreating the wheel every single time. It's interesting because I completely agree with Disha. Take chunks that are doable, but at the same time, I think we also have to look big. We have to look small and big at the same time. And that's how we get through this, because this is both a big and a small or problem, or issue. And the last thing I'll say is I feel very optimistic, because I think that in the next 2 or 3 years, some level of policy and operational consensus will begin to emerge. It feels like that's going to happen. And I know that Stephen is about to reappear magically to close out. There he is. It's like on Bewitched, calling Dr. Bombay. So, so I just wanted to say, panelists, thank you for the most amazing panel. We really could have made this a 2-hour panel.
It totally could have been 2 hours. So I appreciate everything you guys were able to share. And thanks to everyone for all the great comments and discussion in the comments box. That's exactly what we want to see. So thank you all so much. Of course, thank you to all of our panelists. Thank you, Mark. Of course, thank you to our sponsor, LexisNexis, and all of our other sponsors of this event that made it possible today. My big news about the Digital Virtual Health Series was probably a little bit predictable, and I'm still very excited about it. We launched this program in January to do some things for the community in the first half of the year, because we knew we wouldn't be able to do live events until possibly the last half of the year. We're still planning on doing as many live events in the last half of the year we can, but the Digital Virtual Health Series has been so successful that I'm very happy to announce that we're extending it through December of 2021. And if you guys go back to the website, which you'll be redirected to when I end the session, you'll be able to check out all of the months and all of the topics and everything that we're going to cover. So we're very excited to have the success in this program, and are happy to do it again through the end of the year. So thank you, everyone, again. Thank you all. As a reminder, all this stuff will be available on demand anytime you want to watch it. Have a great afternoon, and we'll see you guys next month on April 20th.
Thank you all. Thank you.
Bye.